Good afternoon. Thanks for coming. I hope everyone appreciates the subliminal advertising, but I'm taking this off because it's muffling my voice too much. Anyway, so I'm the Rhode Island chair of Physicians for a National Health Program, which is a group of 20,000 physicians nationwide who are advocating for a single payer national health insurance system. So I want to talk a little bit about Medicare for all. Is it even possible? And why is there so much controversy about this? Next slide. So most medical talks usually include a disclosure slide. This is to show that I don't have any commercial interests, nor am I paid to do this, as will become abundantly clear why in a few moments for all the people who are listening to me. So, next slide. So, Medicare, advance again. Medicare for all is a very simple concept, really. Next slide. There we go. So in a healthcare system, you really have two things. You have people who are seeking care, that's on the left, and then you have the things that you need in a modern health system to provide that care. You need personnel, you need facilities, hospitals, clinics, and you need materials, pharmaceuticals, surgical implements, et cetera, et cetera. So in a capitalist society, you need one more thing, and that's that big, massive stuff in the middle, which is money, which keeps all of this going. Advance the slide. So in this country, we have chosen to employ a number, on one more advance, a number of different entities whose sole purpose is to handle the flow of that cash from the people on the left to the facilities on the right. And there are many, many, many of them. Some of them at the bottom are actually governmental, and some of them at the top are private. Advance the slide. All single payer does is just eliminate all that stuff in the middle. The people getting care get it the same way. The people delivering the care do it the same way. The only difference is the money is all being funneled through one channel, and that's the single payer national health insurance plan. So a healthcare system should deliver care. That's its purpose. Unfortunately, our healthcare system delivers some other things as well. Next slide. Bankruptcy. We're unique in the developed world that our healthcare even does this. 60% of people who were declaring personal bankruptcy in 2016, and this hadn't changed before or after the implementation of the Affordable Care Act, by the way. 60% of these people cited healthcare bills as the precipitating event that led to their bankruptcy. And of those, 75% had private insurance at the onset of the illness or injury that bankrupted them. Another unintended consequence, death. We know that people who are not insured in the United States have a mortality rate of 1 per 1,000 per year. There is also a mortality rate which is harder to get at for people who are underinsured, people who have insurance but are still paying at least 10% of their income in addition to the premiums for their healthcare, for their health insurance to obtain healthcare. And the third thing, rising cost. The Affordable Care Act did not change this. It injected more money into a system that basically doesn't work. The cost of our healthcare system continues to rise as a percentage of our GDP and out of proportion to the rise of the average income. The average income in this country has been rising by about 2 to 2.5% over the last 40 years, roughly paralleling inflation. The average health insurance premium has risen by 5%. By 2025, CBO estimates are that the average health insurance policy in this country will equal 50% of the average person's income. Next slide. So what does this system deliver as far as healthcare is concerned? Well, as I feel like I'm actually giving Bishop Nisley and Reverend Mark's talk with slides. Anyway, what it also delivers is just bad care. This is one, the PNHP has a million of these slides, but this is one of the more shocking. Maternal mortality rates, the rate at which women die while giving birth, is 10 times that of Australia in this country. Australia has single payer national health insurance. And it greatly, and it's a multiplier of Canada, France, UK, Germany. We do not do a good job of taking care of people in this country. Next slide. So, advance. So this is a graph comparing the life expectancy at different ages for 17 developed nations, including the United States. And you can see at the bottom, well, on the left-hand side is our rank That's what the graph's about to look at. And then on the bottom are age groups, 0 to 1, 1 to 4 years of age, et cetera, et cetera, et cetera. Next slide. So you see that for most of our lives here in the United States, Americans have the lowest life expectancy in the developed world. But at age 65, something magical happens. Next slide. Average life expectancy climbs until, but if you survive to your 90th year, Americans have the second longest life expectancy behind the Japanese. What changes at age 65? Any guesses? Okay, next slide. So we don't do a good job taking care of people, so our system must be cheaper. Well, as unfortunately Bishop Knisley and Reverend Mark has already revealed, in fact, the opposite is the case. We have the most expensive healthcare system on earth. In fact, our public spending, what the government spends for healthcare in this country, already exceeds most of the developed world. When you add on the private spend, it clearly, we're an outlier. And I'll add that the bottom 3 countries we're being compared to, Holland, Germany, and Switzerland, all have multiple private health insurance companies, except that they're very tightly controlled, as opposed to the United States where they're barely controlled at all. Next slide. So we have a lot of other models to look at. Next slide. So we could have a national health insurance where the government is not only the insurer, it owns the hospitals, it employs the doctors and the nurses and the pharmacists. United Kingdom, New Zealand, and Italy all have that model. That would probably be the closest thing to what most people consider socialized medicine. It's 70% less expensive. And as we've seen from the previous slides, they do a better job taking care of their people. Another model, next slide. Medicare for all. This is what we're proposing. It's already being done in Spain, Ireland, Canada, Australia, and several other countries. This system is where the insurance company, the government is the insurer, but hospitals, clinics are privately owned, physicians are self-employed. So the only thing that changes with Medicare for all is the way all of this is funded. Next slide. So the expensive European countries, or the ones with the most expensive healthcare system, all have this, it's called the Bismarck all-payer, because the system on which our system, by the way, is modeled, not very well, was actually originated by Otto von Bismarck. So our system in a free country is based on a plan by a German autocrat from the 19th century. Switzerland, Netherlands, Germany, France, Belgium, Austria all have this system. They have private healthcare companies, but they are so tightly regulated, they're not allowed to throw people off their insurance. They're not allowed to tailor their plans. They have to cover the care that people need. Finally, we have the United States. Advance the slide. Where we are, once again, unfortunately unique, and we have the most expensive, most uninsured people, and the shortest life expectancies in the developed world. Next slide. So where is the money going? We just saw on the previous slide, we're spending more than any other country. And advance the slide. Where's the money going? So you can see over the last 40 years, the number of people who actually provide care has increased. That green bar is only as thick as it is so that you can see it. If it were to scale, it would be invisible, as opposed to the big, large red mountain, which are the number of people involved in the actual administration of this system. For an example, Mass General Hospital has more people in their billing department than they have beds in the hospital. Toronto General Hospital, which is roughly the same size and roughly the same number of people served, guess how many people they have in their billing department? Three. You have a single payer. It's all done by computer. You don't need a lot of people in your billing department. Next slide. So in addition to being inefficient and deadly, our system is also quite racist. It's easy to understand why. Since access to private health insurance plans is proportional to your income, and poverty falls disproportionately on communities with color, it's not surprising that in this slide, as you can see, Black Americans are uninsured at twice the rate of white Americans, Hispanics at 3 times the rate, and Native Americans at 4 times the rate. So our access to healthcare is partially determined by our race because it's tied to wealth. Next slide. Not surprisingly, this lack of access to healthcare kills people. Black Americans on average, have a 4-year life expectancy shorter than white Americans. For some reason, Hispanics do better, not sure why. Next slide. And of course, racial differences in maternal mortality. Black women die almost 4 times more frequently than white women when they give birth. And it's clearly tied to their access to healthcare. Next slide. But when you go to a system where income and wealth do not affect how you get care, this shows the likelihood that a Black man with any of these diseases is going to die in a given year versus a white man. And it turns out mortality rate among Blacks in the VA is slightly lower when you control for age and illness compared to Caucasians. New heart attacks, much lower. And then stroke, almost the same, but maybe slightly lower, not statistically significant in all likelihood. So this is not an ethnic or racial problem. This is an access problem, and it's racist. So next slide, why does our system not work? Well, as our friend Jim Cowan likes to say, I can't really do his accent, and especially with somebody who actually has an English accent, I'm not even going to try. So it's because it is not fit for purpose. And so next slide. Why not? Because you can't insure a person's health. Why not? You can insure a car. Car insurance works very well because you know how likely is it your car is going to get into a wreck, depending where you live, and how much is that car going to cost to replace? An individual person does not know what their healthcare cost is going to be next year. It might be very low. You might also develop leukemia, and it goes into the hundreds and thousands of dollars. That's why the ACA individual markets keep failing, because insurance companies do not want to insure individuals. It's too risky. Next slide. It's easier and better to insure a group of people, because when you have a large group of people, you may not know which ones are going to have a heart attack, but you know approximately how many of them are going to have a heart attack. So you are spreading the risk. And the larger the group is you insure, the more the risk is spread and the better the insurance works. Why not have an insurance pool of 380 million people? Next slide. So the other reason why it doesn't work is that private insurance is not paid for depending on what your income is. It's paid for depending on how much insurance you want. You pay for what you need. The problem is you don't know what you're going to need. So to ask people to play Russian roulette with their health insurance is insanity. A single payer, a governmental system, on the other hand, is paid for by taxes. Taxes are proportional to your income. So your health insurance is always affordable. Medicare for All achieves all this. There's one group, so there's no groups competing with each other for the healthy patients. It's one insurer, it's paid for by taxes, so it's affordable to everyone equally. Next slide. The other problem with private insurance is it can't control costs. For instance, for-profit insurers are disincentivized to control costs. Their primary fiduciary responsibility is not to their subscribers, it's to their shareholders. So they have a fiduciary responsibility to maximize their stock price. Their stock price is in part determined by top-line revenue. It's also determined by how they perform year to year. The most practical and easiest way for them to increase revenue is to increase premiums, which is why last year, after a banner year of profit, the United Healthcare in the state of Rhode Island asked for a rate hike anyway. They didn't need the money, but they needed it for their stock premium price. So they are incentivized not to keep costs down. Not-for-profit plans like Blue Cross don't really have that problem. Their problem is they're too small to control cost. Rhode Island Blue Cross only controls about 15% of the healthcare spend in the state of Rhode Island. They are in no position to force large pharmaceutical companies to lower their prices. They can't control cost. Next slide. So what are we doing about this? Advance. So there's 2 slides, and unfortunately Linda caught this because I didn't update the slide. There are 2 bills in Congress right now. The numbers you're seeing up there are actually last year's numbers. This year, the Jayapal bill, the House bill, is 1976. And the Senate bill, the Sanders bill, is 1129. What do they have in them? The Jayapal bill is a bit more comprehensive in that it also pays for long-term care, which is a problem we are going to have to deal with sooner or later anyway, as Alan can attest. Nursing home costs are out of control. We'd have to figure out some intelligent way to pay for them, unless we're comfortable with people just dying in poverty at home. So it's both bills propose comprehensive coverage, all the services that are considered medically necessary. All US residents are covered. You choose your doctor. Since there's only one payer, everyone gets paid. No premiums, copays, deductibles, or surprises. Prescription drugs prices can be successfully negotiated because the United States is a very large entity. It can control costs just as Canada is doing right now. And I would add, yeah, Medicaid reimbursement is terrible, but our senators and our representatives don't have Medicaid as their insurance and never will. When you and Senator Reid have the same insurance, he has a lot of incentive to make sure that it's a well-funded insurance plan. Next slide. Next slide. Next slide. Okay, just keep advancing till we're out of this slide I've already talked through. Okay, so that's what we're proposing. What is actually happening? Well, what's happening is that Medicare is under assault. Newt Gingrich in 1995 on camera said, "We believe it's going to wither on the vine because we think people are voluntarily going to leave it, voluntarily." 2 years later, under Bill Clinton, the Medicare Plus Choice program was invented, which became under George W. Bush, the Medicare Advantage program. Now, either of these presidents could have just expanded Medicare to cover prescriptions. Instead, they chose to create a program which would be profitable to private insurers willing to co-insure Medicare recipients to cover the things that Medicare didn't cover. There were actually Medicare cuts in the Affordable Care Act, which is very seldom discussed. The ACA, in order to make it more budget neutral to attract Republican votes in Congress, cut $60 billion in Medicare funding to safety net hospitals over 10 years. And of course, what are safety net hospitals? Hospitals in rural areas and the inner city, serving people who generally don't vote or are prevented from voting. Now we have a new threat, which is called Medicare Direct Contracting Entities, which was come up with by the Center for Medicare and Medicaid Services, which after all is controlled by political appointees. This plan was invented under Donald Trump, and unfortunately it is moving forward under the Biden administration. It has the potential to switch 30 million Medicare recipients to private health insurance plans, which will become managers of their insurance. Next slide. So does Medicare for All make sense? Next slide. It does. 29 studies, including one done by the extremely conservative Mercatus Institute at George Mason University, funded by the Koch brothers, found that switching to a Medicare for All plan would save, they estimated $3 trillion over 10 years. Most other financial evaluations actually put the number far higher. 219 economists, there may be more by now, this slide's a couple of years old, have concluded that it doesn't make economic sense to do anything else. Next slide. And to Bishop Nisley's point, healthcare is not a service that should follow standard market rules since people's lives are at stake here. It should be provided as a public good. We don't fund our Army and our Navy by state. Sorry, Rhode Island, you didn't pay enough taxes. If the Chinese invade, you're on your own. No, it's a national good, and we pay for it nationally. Health, we're all equally susceptible to disease. We should be funding it equitably. Next slide. Where is the cost going and coming? So with more people insured, we have no one insured under our Medicare for All, 12% increase in costs overall. But that's made up for, next slide, by an estimate 19% in savings. Next slide. The complexity of multiple insurers and the billing that they require goes away. 9% of total costs saved. Next one, 5.9% pharmaceutical prices, 2.8% uniform rates and delivery side, and finally 1% improvement in detecting fraud and waste. The system we have right now, the arrangements that private health insurance companies have with institutions, hospitals, clinics, et cetera, is proprietary. With a single payer system, all of that is laid bare. So if some place or some person is charging a lot more than their peers, it becomes immediately apparent. It is far easier to detect waste and fraud in a single payer system. So there are other options that are being touted right now, but all other options besides single payer miss the savings of single payer and allow administrative costs to continue growing. They leave millions uninsured, as we have 35 to 40 million uninsured right now. They do not control skyrocketing drug costs. They do not cover all necessary care. They do not eliminate premiums and deductibles. In fact, they rely on them. They don't allow choice of doctors. Give you an example, Medicare Advantage. 1/3 of Medicare Advantage plans nationally do not include a National Cancer Institute hospital in their system, because to include those facilities, you're attracting expensive patients. So it's the way they keep expensive to take care of patients out of their plans. These other options delay the care we really need. And with that, I'll conclude. Thank you.